Good morning, friends. It's indeed a pleasure to be here in Belgrade, Serbia for the knee symposium. I am Dr. Vaibhav Bagaria. I am the Director of Orthopedics at the Sir H.N. Reliance Foundation Hospital in Mumbai, India. In today's talk, we'll talk about when to use the stem, why we prefer cementless systems, what are the key principles of cementless fixation, and when not to use the cemented stem and use why not to use the cementless stem and when to use the cemented stem. The indication for the use of stems are very clear. They are used in severe deformities where it helps to correct the alignment and also provide additional support. It is preferred to use them whenever there are bone defects which are larger than 10 millimeter. They are also used for instability. Whenever we use constraint, they help to prevent loosening. And they are also used when we have to bypass the weakened bone, as is the case with the stress fracture. Of course, they can also be used when the patients are obese, when the BMI is typically more than 35, and in cases of revision surgery where we have combination of multiple of the factors that I just spoke about. For example, in this case, you will see there is a very large deformity, the bones are very osteoporotic, and we'll probably be using a constraint system. And as a result, when we look at this patient, we had to use a stem. Now, what are the key points in executing a stem? Now, the first aim is to have a press fit. We should always ream it in a way that there is a press fit of the stem. We use the smallest possible length, but at the same time, it should be large enough to bypass the stress region. I use uncemented in majority of cases and cemented only in very osteoporotic or old fragile patient. Also remember that the modern system allows you to dial in, and we'll talk more about it in coming slides when we are doing this surgery. First, let's look at what's the press fit, and it's important to know the reamer size. So, for example, in this particular case, if you're using 14 millimeter, remember that the flutes are 0.5 millimeter proud. So, for a 14 millimeter press fit stem, you use a 14 millimeter reamer. And remember that the stem shaft is only 12 millimeter when the flute begins, but the diameter of the cutting flute is almost a millimeter higher, which is around 15 millimeter, because it's zero point 0.5 each on the each side. The other concept to know when you are dialing in, to when you are executing them, is to dial in. Sometime your femoral or tibial shaft may not align properly with the base plate. There you can do what's called as dial in by providing an offset. So remember, when you are dialing the offset, you must know how many millimeter to dial in and in what direction to dial in. It's often there are numbers on the thing, and it could be 2 millimeter, 4 millimeter, 6 millimeter, and the dialing in direction is there. A simple trick that I use is like a watch, as a clock. I always, when I dial in, I tell the circulating nurse to write it on a board. For example, if I'm dialing it at 11 o'clock, in this case it's mentioned as 1. So I say 11 o'clock 4 millimeter. So that way we can dial, and you can see from the next picture how there is an offset of the stem in respect to the tibial shaft, tibial base plate. In next case, if you look, it's a failed uni surgery wherein we have to use, and again I have used a very short stem along with a wedge. Another case example is when you use it with a stress fracture. You'll see that there's a clear stress fracture at the upper third of the tibia, and the reason why this stress fracture was there, because the patient had significant varus deformity of almost around 25 degrees, and here you will see that we have bypassed that. We have put a screw to have the bone defect covered, and also I've put a small derotating screws. It's not always necessary to use such a plate, because inherently the stress fractures are stable, but having a plate allows for early mobilization and pain resolution. And indeed, if you look at this scanogram, the alignment, because the stem seems quite good with a very residual 2 degree of varus, and at 6 months follow up, you can see that the fracture has completely healed. The patient is painless and wants a second side to be done. Why do we use cementless stem? Number one, the reason being is that it's a biological type of fixation. And once you have put that, it also ensures an improved long term durability of the whole construct. You preserve bone because you do not want to remove any endosteal bone, so preserving the supply, and that is also responsible for a reduced risk of aseptic loosening. And therefore, whenever you have any of these cases, for example, if you have any failures, then the future revisions are easier in these cases. Of course, the modern designs have also improved a lot, and there are surface coating like HA for enhanced osteo integration. The tapered or fluted stem ensure enhanced metaphyseal or diphyseal fixation and consequently improved stability. And the modularity is there. That means that we have an ability to use different sizes and diameter with both femoral and tibial components. So, for the most cases, the cementless system suffices. But there are a small proportion of people in which we have to use cemented stem. And for me, it's older patient who are quite osteoporotic with large, broad canal, where there is an inability to get a press fit. And a very small and a doubtful indication is when you want the stem to act as a antibiotic delivery system. It's not often that you want to use it, but in those cases where you want cement to have a large dose of antibiotic, you may think of using cemented stem. So to conclude, I have a very low threshold for using stems. In younger patient, biological solution like cementless stems are preferred. In older patient, more mechanical solutions and cementing is sometimes required. The aim is to obtain a press fit. You use the largest diameter without removing much of the bone. It's also important to ensure that the appropriate length is used. It should be the shortest possible length, but at the same time, it should bypass the stress region. And when we are dealing with large metaphyseal defect, it is best to use it with sleeves or cones. So with this, I thank you for your attention and welcome all of you to Mumbai. We are conducting a course TTGR next year between 10th to 12th January. It's quite an advanced course for advances in joint replacement, both hips and knees. And I look forward to welcoming you all in Mumbai, India. Thank you.